All right, wonderful. Well, good afternoon, everyone, and thank you for having me here today to share the UPMC experience with COVID-19 related care. And what I'm really going to focus on is how we invested resources and energy into engagement from providers across our health system, as well as patients. And we are a 40 hospital health system across 3 different states, New York, Pennsylvania, and Maryland. And when we went into the COVID-19 pandemic, we approached all COVID-19 related care with the goals of equity and enhanced access regardless of patients' zip codes. And so the 3 key areas that I'm going to discuss today are 1, how we built an embedded platform system so that every single patient presenting to any UPMC hospital had the same opportunities to enroll in clinical trials and receive experimental therapies as patients that go to larger academic hospitals. And so pre-pandemic, you could only enroll in a clinical trial if you were at the academic centers, and now, with some exceptions, but we wanted every patient with COVID-19 to have the same opportunities. 2, our process for allocating scarce resources throughout the pandemic. And then 3, our very robust monoclonal antibody infrastructure, which we think will serve as a model for rapid implementation of outpatient care for other systems even past the pandemic. So in early March 2020, when this was all kind of coming to really late February, early March, we were all trying to figure out what to do with COVID-19. And I am an IG pharmacist at our main academic hospital. And I emailed our head of infection prevention, who was working on COVID-19, of course, at the time. And I was like, there's a lot of really crazy stuff coming out with pharmacotherapy, and I'm afraid patients are going to get hurt. Quite frankly, I don't know that anything helps these patients at this point, but I don't want them to experience harm. Is anyone working on a guideline or a COVID treatment guideline? And he said, nope, congratulations, you're it. And I was like, well, I'll write a guideline, but we should do this on a system level. I shouldn't just do this for my hospital. Doesn't make sense for multiple pharmacists or multiple physicians to be working on the same content. And so within about a week, we had support from the C-suite to form what we call the System COVID-19 Therapeutics Committee, which I have chaired since March of 2020. And what this committee was a subsection of our Pharmacy and Therapeutics Committee for the whole system. And we were given the ability by leadership to make therapeutic guidelines changes and decisions without going to formal P&T approval. So we removed a lot of the red tape so we could be nimble and adjust accordingly. What we also did at that point in time where we were given resources. And so I think leadership buy-in and resources are going to be key across all of these equations about engagement and access, as well as information technology. And so we integrated very closely with our IT teams, what we call our e-record team. We actually have 5 electronic health records across the UPMC enterprise. We have 7 if you count our outpatient systems as well. And so we needed to do everything 7 different times whenever we made a change. So a lot of IT, and with those resources, we also were able very quickly to what we call lock down almost every medication that was being suggested for COVID-19. We built alerts, we built reports. And so our central teams every day get an email, which has an Excel file of every patient in the hospital, on any of these therapies. And then we used that central team and built local teams that we worked with closely. We had weekly huddles with them. So they were screening their patients and really just ensuring everyone was getting the same kind of care. The last thing that we did is we created what we call a culture of learning while doing. And so we felt pretty strongly that you couldn't ask people to follow guidelines, which largely said don't do anything for these patients, unless you gave them the ability to feel like they were doing something. And we knew we needed to have buy-in from all of our local providers and from patients. And that was essential for engagement on every level. And so we recognized that we are always faced in healthcare with the desire to do something, which is treat the patient. So in the early days, that would be give hydroxychloroquine, versus learn, which is really test these therapies in randomized controlled trials so that we can do the best thing for all subsequent patients. And so we recognize this kind of juxtaposition of the need to do and the need to learn. And we built a system in which those things could happen simultaneously and to get culture and buy-in for that. So let's talk about that clinical trial first. Throughout all of this, we had an expression we adopted that it's not about the drywall. So it's not about where the patient lives. It's not about where the patient's located. It's not about the patient could be in the hallway of an emergency department in a pop-up hospital because of overflow. None of that mattered. All that mattered was their clinical status, and everyone should get the same care based on clinical status. And so, traditionally you'll say, well, you have to be in an ICU to enroll. And we knocked that down pretty quickly, recognizing it was about the patient at the patient level and not about, their location. And so to make this learning while doing culture, you have to get every prescriber and every patient to buy in. And again, the way you do that is you give them the option to do something, even when they're choosing that option to do something. And that actually leads to them doing nothing, which would be enrolling in a trial where they might get placebo, or because pragmatically we didn't give placebo, they just got standard care, which was supportive care at the time. And so we became the US leading center for the global Remap CAP trial. Remap stands for Randomized Embedded Multifactorial Adaptive Platform. So this trial was completely integrated into the EHRs. We have Cerner and Epic as our two main forces for two different sections of our health system. And that aligned very closely with our routine clinical care. So what the platform did was it enabled the trial team to evaluate multiple treatment strategies at the same time for the same patient. And it even assessed if interactions occurred between patients with different interventions. And so analytically, what would happen is that this happened continuously. And so patients were randomized in an adaptive response fashion to a domain that they were more likely to experience treatment success with. And because of this Bayesian model and that mentality, that also really helped get patient buy-in, because we told them, like, you're going to get the most likely treatment that will benefit you, but that could in fact be nothing. And we saw that at the end when we were randomizing with hydroxychloroquine, is that almost all patients were randomized to standard care. But we knew that this could not follow a traditional academic model. We had to reach patients where they were and reach them everywhere. And so we broke out of traditional investigational drug services structures. So how we did that is every patient that came in the hospital had an intake form completed. So this is a patient's chart in Cerner as an example. We built this COVID-19 resources tab, and then this form that essentially every provider would fill out for every patient. At the end of this form, there was a question that said, are you interested in learning about experimental therapies? If the patient answered yes, that triggered an email to fire to a central care team. And then that central care team would then start the process of trial enrollment and any other opportunities we provided. If the form had been completed, or if you were not a physician, this is what you were faced with. So you had links to all of our resources, which were all integrated on our InfoNet, and which is an intranet, and then as well as an external internet for resources. So here's what this looks like to walk through this process. So this is the entire Remap process, and it starts again with the prescriber completing this intake form after speaking with the patient. If the patient was not interested in learning more about experimental therapies, they were excluded from speaking with the research team, and they would just receive clinical care. If the patient was interested in learning about experimental therapies, therefore they answered yes, then again, that alert would be sent to a central research coordinator, and the CRC would then screen the patient for inclusion and exclusion criteria for each domain. If they were completely excluded from the trial because they didn't qualify for any of the treatment domains, they would receive routine clinical care. If they were eligible for enrollment, the CRC would contact the patient or their legally authorized representative via a video call or a smartphone call. Now, this is where we really use technology for engagement. And we learned very quickly that not every patient has a smartphone and not every patient knows how to use a smartphone. So we had to get pretty creative. We actually had nursing leadership on every unit of every hospital that would be the go-to contact. If a patient couldn't use a smartphone, that nurse would come in with their smartphone, or some of the attendings would use their smartphones. We got really creative, but all of this consenting was done over video conferencing. Before we went live with the trial, we actually tested this on all of our grandparents and some of our other underserved patients so that we could think about and overcome some of these access issues. A physician on the central research team would then join the call for patient consent. If the patient refused consent, they would receive routine clinical care, and this note would go into their resources tab saying they were ineligible for the trial. So we were very transparent. Everyone on the care team could look and know exactly where the patient was in the phase of the trial. If the patient consented to study participation, they were sent a link electronically to sign a consent form. So this was all done via DocuSign, again, on a smartphone or a tablet. And then from there, they were randomized and enrolled into the trial. After that happened, any provider, if once they were randomized, that opened a chart and placed an order, any order, they would get a pop-up alert to order the medications that the patient was randomized to. So again, this was all very pragmatic, and most of these medications were dispensed from local central pharmacies rather than investigational drug services. Once the patients enrolled, what they were enrolled to and randomized to also appeared on the COVID-19 resources tab. So this was all open label, which is the only way you can really make this happen. And so the study recipe would be here. And again, very transparent for buy-in. And we also wrote a note in the chart, and we had a hotline that patients or providers could call 7 a.m. to 9 p.m., 7 days a week, as well as an email address to answer any questions about the trial. So moving on, how we allocated scarce resources. So this was most prominent with a drug called remdesivir, which was an antiviral medication used for COVID-19. It got emergency use authorization in May of 2020. And when it first was authorized, it was extremely scarce. This was the first shipment we received from the Pennsylvania Department of Health. You can see we got 36 vials for the entire health system, which is only 6 patient treatment courses. And at the time we had 204 patients admitted to the hospital with COVID-19. So how do you even begin to pick which patients should get remdesivir? And the thing I want to point out is that first come, first serve is not the answer, because it inherently disadvantages patients from underserved areas because they are less likely to present to healthcare earlier. And so we knew that wasn't an option. So we met with ethicists and patient representatives. We actually put together a whole team of ethicists, community members, legal scholars, public health, disaster medicine experts, and then diversity and inclusion experts, as well as physicians and pharmacists, to come up with an ethical standard. All of this information was housed on our intranet. This is how it was displayed. And we had everything about the allocation system. I did hours of virtual training sessions with all local representatives on how to screen patients for inclusion, et cetera. Our model policy for ethical allocation is publicly available. You can find this on Pitt's website. But what the main principles here are one, we wanted to safeguard public health by allocating these scarce resources in a way that maximized the benefit of these resources to the community. Number two, we wanted to lessen the impact of the social inequities of COVID-19 and the outcomes in our disadvantaged communities. And so we ensured by the way that we use technology to screen every patient, that no patient was refused access to care based on age, disability, religion, race, ethnicity, national origin, immigration status, gender identity, sexual orientation, or their perceived quality of life. And then finally, our third guiding principle was that we wanted to ensure that all patients received individualized assessment by a clinician based on the best available objective medical evidence to be entered into the allocation system. So what happened is every single day we got a report of every patient admitted to every hospital. This was then sent to local teams via Microsoft Teams. So we used a team sharing platform to divide out patient lists. Local teams would then screen their patients and talk to local providers, and then all eligible patients for the drug based on clinical criteria would be entered via a Microsoft form into the lottery. Patients who were essential workers or patients who came from a high area of deprivation index score area, which would be an underserved or a disadvantaged area, they were given increased odds of being allocated medication. And then patients who had a poor end of life prognosis were given decreased odds. Importantly, they were still given a chance. So it's inappropriate to completely exclude these patients, but it is appropriate to decrease their odds of allocation based on the overall benefit to public health. And then we would run the lottery based on our weekly allotment of drug and our weekly expectation of patients admitted. Again, not first come, first serve. And then patients who were allocated medication would be communicated with by the central team to local teams. Here's just examples of our information. And I only show this just to show like how extensive these documents were, all electronic, all linked, and all accessible at all times. And then last but not least, I have to give credit to Dr. Taylor Lincoln. She specializes in palliative care training to improve end-of-life care for critically ill patients. And her work promotes high quality communication, which is aimed to ensure that patients are receiving care consistent with their value system. And so we created these documents to guide providers on how to communicate with patients and their families if they were or were not allocated medications and how to handle emotional responses. And then last but not least, our monoclonal antibody system. And I know I'm coming up on time, so I'll go through this quite quickly. But this is the map of Pennsylvania based on area of deprivation index score. The dark red is a 10, which is the most underserved area. The dark blue is a 1, which is the least underserved area. You can see that UPMC's representation is largely Western Pennsylvania, which is a lot of red. So we have a lot of underserved patients. This is where we built monoclonal antibody systems. So if you superimpose that on that map, we basically have a clinic in almost every dark red area. We built over 45 monoclonal antibody infusion systems. And the reason we invested in this is because we believed in the early data that if you give these to patients, it would decrease their likelihood of hospitalization and death. Of course, if you did not buy into that data early on, this is not something you would have invested in, but we thought these were very promising therapies, and that panned out to be true based on our own internal data. So this was a worthwhile investment. But your patients that need these therapies are in these underserved areas, so we had to go to them. We invested an unbelievable amount of FTE and time into patient outreach. And so we said we would treat every patient regardless of provider. We waived all patient responsibility for these therapies. The drug is actually free because it's donated by the government, but we don't charge for the test. We don't charge for the infusion. This is upmc.com, so it's an external website. Anyone can go and download this paper referral form and fax it to our central care team, and we can get patients scheduled regardless of where they come from. This is very high level, how many different aspects go into this care team because it is inpatient and outpatient. So we have everyone from design, communications, marketing, legal, staff support, pharmacy, operations, etc. These are some examples of materials we made. So this is a card that we put in our testing centers. So every patient that came in with a test went home with this card. And so if they tested positive, they could then call themselves. We established a hotline that we staffed 9 to 9, 7 days a week. The patient could refer themselves without a PCP. Again, you need to do these kinds of things for patients that don't access healthcare, don't have health insurance, might not have a primary care provider. So the self-referral hotline was essential. These are materials we developed in Spanish and other languages. And then finally, these are data to support that if you invest in this outreach, you make a difference. So when this started, the proportion of patients who tested positive and were eligible for monoclonal antibodies to receiving treatment was a ratio of about 1 to 100. After our outreach efforts, that came to 25 to 100. So the program grew tremendously in ensuring that eligible patients got treated. The other thing that happened is the proportion of patients who tested positive that ultimately got treated amongst white patients and Black patients, there was a big disparity at the beginning. And after our outreach efforts, we were able to close that gap such that the likelihood of treatment was equal after all of these operational builds went into place. The last thing we did was patient testimonial cards. So patients that received therapy that then felt better, that were willing to talk about it. We developed these kinds of cards and distributed them. We did radio, we did other kinds of marketing and communications, really because we believed that patients that got these therapies had less likelihood of dying. And so we thought it was extremely important that they knew about this and would access care as soon as possible. So these are examples of some patient testimonials. And last but not least, I'm coming up on time. I talked really fast over 3 huge systems. So I know we're hanging around for questions. And thank you for the opportunity. And also, I just need to acknowledge the literal hundreds and hundreds of people that I work with every day across a very massive health system in all aspects of direct patient care, all the way down to people who build the data reports. And so I couldn't do it without them. I can't name them all by name, but it really does take a village. So thank you.